Okay, so short video about carotid artery part 2. Last video we talked about the anatomy of carotid arteries. There's two up front, two that supply the brain, one on each side, the left and the right obviously, and then there's also arteries at the back of the brain, the vertebral arteries, and there's a mixing of those two systems inside the middle of the brain, so-called circle of Willis. So there's alternative channels to get blood flow back up to the brain, but the main one is the carotid artery. And so hardening the carotid arteries we talked about, the risk factors, age, cigarette smoking, high blood pressure, high blood sugar, cholesterol, family history, circulation problems. The most carotid disease does not need treatment unless it becomes severe and you have symptoms which could range from a TIA, which is a mini stroke, which you recover function within 24 hours, or full-blown stroke where you don't recover function. But most people who have carotid artery disease do not need surgical fixes for them. They can be managed very conservatively. Risk factor modification, stop smoking cigarettes. That's really the key to a lot of this stuff. And then blood pressure, cholesterol, blood sugar control, regular exercising just for overall cardiovascular health. And so situations where you need a surgical intervention, very severe carotid stenosis, fair enough. Although there is some discussion about whether anybody who has even severe carotid stenosis needs to be treated with surgery, so-called asymptomatic, even though you got very severe carotid stenosis. Do you need a surgical treatment for that, even if it's very severe, if you don't have any symptoms? Beyond the scope of our discussion here, I just want to give you a kind of an understanding of the equations you face as you go down this road and make a good decision with your provider. But so if you need a treatment, like for example, if you've had a TIA or a mini stroke, it's what we call ipsilateral to the side. So, I wake up one day or I'm reading a paper, all of a sudden my left eye goes black, like a black curtain come down over it. I get worked up with a carotid ultrasound. Yeah, I got a severe left neck artery narrowing, carotid artery narrowing. So it's ipsilateral to the side of the lesion, to the side of the symptom. Or, I'd expect loss of vision, loss of control of the right side of my body, loss of speech ability, although I'm left-handed, so I may not have my speech center on the left side of my brain. But anyway, so ipsilateral event, you recover function within 24 hours, yeah, then you really should think about having a treatment. Again, the timing to treatment, I don't think that's, again, something we want to get into. It's changed a little bit, but in those situations where you have a symptom ipsilateral to the same side as your carotid artery narrowing, then you may need surgical treatment. Just a brief word on diagnosis. So carotid Doppler in good technical lab, in labs that have good technologists and good technical backgrounds, that's a pretty good diagnostic test for carotid artery narrowing. If there's any concerns, CT angiogram to look at it, conventional angiogram where you just go in through the one arteries and do an angiogram. That's also done, although not nearly as much as it used to be years ago, but that's another diagnostic test. It's kind of the gold standard test. MR angiograms, in my opinion, and I may be completely off on this, but this is my opinion. If there's a moderate lesion in the carotid artery, the MR, I think, tends to overread it, makes it look worse. And so, I hate to overread a study and say it's worse than it really is. But anyway, be that as it may, you get the diagnostic test, you have the symptom. What are your options? Well, three options really. Medical management is probably not a good idea. Medical management being the statins and the antiplatelet drugs. Then you need some type of intervention. The three interventions possible: transfemoral stenting, where you go in through the groin artery and you go up there and put a stent across that area there. Carotid endarterectomy, where you actually go to surgery and make an incision about yay big and clean out the blockage. Or transcervical carotid stenting, TCAR, which is a newer modality. So those are the three options. The whole point is to get that blockage out of the way. The one procedure that takes the blockage out is the carotid aneurysm. The carotid stenting and the TCAR, they just kind of open up the channel to improve the blood flow. The reason you have that TIA or a stroke is something breaks off and goes up there. And so those procedures open up that channel to reopen that narrowing, whereas the carotid aneurysm takes that stuff out of there. And there's pluses and minuses to any of these things, but essentially your complication rate to surgery should be in the 2 to 3% range at most, depending on what you do, maybe 2 to 4% if you're symptomatic. So carotid aneurysm, usually I quote 1 to 2% complication rate to surgery. What's the complications of the carotid surgery? 1 to 2% risk of having a stroke or heart problem from the surgery itself. So that's the complication of the surgery. The problem is, if you have a symptom and you have the same-sided ipsilateral carotid artery narrowing, then your risk for stroke, having a full-blown stroke, is a lot higher. So in that situation, it's fair enough. So carotid aneurysm, 1 to 2% complication rate. Transfemoral stenting, 2% complication rate. TCAR, 1 to 2% complication rate. TCAR, there's something called the Vascular Quality Initiative, which is where a lot of data is entered by different institutions, and that data is kind of analyzed and hashed out. The TCAR seems to have a slightly lower complication rate than the other two modalities, and so that, things are heading towards TCAR. The TCAR is just a small neck incision where we put a stent in through a little neck incision rather than going through the groin. And whereas a carotid aneurysm is a 2.5-inch incision, depending on where it is, and we'll just lift that stuff out of there. I'll get into the technique of TCAR versus carotid aneurysm versus transfemoral stenting in another video. But I think there is a tendency now for TCAR to be going up in terms of usage. Transfemoral stenting is probably going down in terms of usage. And then carotid aneurysm, I think, is relatively stable in terms of usage for surgery. Either way, the procedure's done. Carotid aneurysm, transfemoral stenting, TCARs, you're in the hospital all night, go next day. In terms of recovery, not a real painful procedure. Even the carotid aneurysm is not a real particularly painful procedure. Recovery is pretty quick. It just feels like the carotid surgery, the incision, the carotid aneurysm, feels like you pulled your neck muscle for a week afterwards. You really shouldn't drive, because not so much you're going to pull things apart. It's just, if you have to turn quickly, it's going to hurt like hell. So, just a neck incision, clean it out. 1 night in the hospital. Stenting, just put the stent in. You just have a little groin nick, or the TCAR, a little 1/2-inch incision in the bottom of your neck, stent it that way. So there's certain nuances to this stuff that we may get into a little bit, but that's the surgical treatment options for carotid artery lesions that need procedures done. And the results are good. The TCAR has not been around as much. So the long-term, 5-10 year results are not as well known as the carotid aneurysm, which used to be the gold standard and still probably the gold standard, the surgical approach. And then transfemoral carotid stenting, that's been done longer than TCAR with good results. It's just, you have to figure which is the best for you, and that's a discussion you need to have with your interventionalist who's going to take care of your carotid artery disease. But we'll talk about the actual procedure and what it involves at another video at a later date. Just safe to say that really sometimes one procedure is a better procedure for you anatomically than another one.